I have it at 6:01. All right. Good evening or good morning or good afternoon, depending on where you are. My name is Thomas Higgins. We appreciate you all joining us for this AO Trauma North America webinar. And what we hope to tackle today is practical clinical solutions for pain control. My name is Thomas Higgins. I work at University of Utah. You can see our panelists there are guys who've been pretty foundational in our sense of this in orthopedic trauma to date. We have Joe Shu, who works in Charlotte, North Carolina, and Hassan Mir from the Florida Orthopedic Institute in Tampa. These two guys, along with several of their co-investigators, have really been sort of foundational in the research on the problem that we've had with opiates and on trying to find solutions. In terms of our disclosures, both in terms of funding and consulting, these are they listed here. I will give you a second to actually look at them. It doesn't appear that any of them directly influence what's going to be said tonight. But that is yours to judge. This is just an overview, but essentially we're going to talk about pain management, and we're going to talk very briefly about where we are right now. Because, you know, when we started talking about this 10 years ago, first thing I had to do was convince people there was a problem. That's over. Then each one of us is going to try and very briefly just give you 3 take-home tips that you can use in your practice. And then we're going to spend the lion's share of the next hour just discussing practical problems and questions. I've prepared a long list of questions for our panelists, and I just have to ask them. They actually have to come up with the answers. Looking forward, this is what's coming up. These two both looked interesting to me. And God knows it's something I could improve on in both. Deformity correction and planning is the next webinar from AO Trauma North America. That's October 7th. And then November 1st is how to get more out of the STAPA or the AIP approach. So let's just dive right into it. We are going to talk today about, first, what's the problem? So we're going to do an ARS, which is audience response. And I want you to answer this question, and we'll just throw this up there for a second. I'd just like to answer for your community. What we're trying to do here is prove a point, or at least find something out about how things have changed. Because these are the questions that we asked of the OTA membership in 2011. And then Mackenzie's going to share the answers with us. So it says, to my knowledge, person in my community has died of a prescription opiate overdose. I trust you all can, Joe or Hassan, nod if you guys are seeing what I'm seeing the answers. So it says 45% said yes, 55% said no. All right, so we close that and go to the next slide. When we asked that question of the membership, I'll be honest with you, this is not what I was expecting. We asked that question, the OTA membership in 2011, we had almost the exact same answers, okay? Now let me try the next ARS question. To my knowledge, a person in my practice has died of a prescription opiate overdose. All of this is anonymous. I can answer yes to that question. The answer here is 13% said yes, 87% said no. And if we look at where that was, before it's 12%. I mean, in a way, it's strangely consistent. Honestly, I thought that the numbers would be higher, quite honestly, currently. Because let's look at where we are as a nation. And forgive me, this is restrained largely to the US, not all of North America, but this is what we have data on. So, right, the darker the colors here, the higher the rate. This is rate of prescription, 2006. You can see that where I live and parts of the Southeast were kind of leading the league. By 2012, we get into the height of it. Almost every state is higher, with the exception of the Dakotas. California, and a couple others. And now, through public awareness, through the works of guys like our panelists, I think we've made some headway here. You see this, still a problem in the lower Midwest and the Southeast, but prescription rates definitely down. Now, prescription rates are one thing. This is by state. What if you look at it in a more granular fashion? Again, in these are the same plots. All this is from the CDC. These are the same plots in 2006. Now watch the map transform. 2012 and 2014 is probably when we really peak out in this, but almost every area is more filled in on this map and darker. And again, we have made progress, but despite that progress, again, you look at certain, this is Emory County here where I live, not where I live, but in my state, and in many counties in the lower Midwest and in the Southeast, it's still a pretty distinct problem. And I think each of us in various times speaking have addressed the fact that orthopedics is a real part of this problem. And the other thing that we really focus on is overdose, right? This is year over year change in overdose rates. It's increased in a couple states, it's decreased in a couple states, but in the vast majority of the states, it's about flat. So the number of prescriptions is down, the overdose rates aren't down yet. So what I would say is essentially we've made progress, but there's room for improvement. And I think the panelists would agree. So I only give you that introduction so that we know that it's easy. And if you ask, we did this in our practice, how much have you cut back on opiate use? I mean, across the entire orthopedic department. We all thought we had cut back more than we had actually cut back. Yes, we've cut back. Probably not as much as we think. So now I'm going to ask our panelists. I'm going to stop sharing. I'm going to turn it over to Joe. Joe, give us your 3 tips that you find most helpful in clinical practice. I want to remind our participants that your chat is open there for questions, and please jump in at any time.
All right. Can everyone hear me? Actually, let me scroll to the top. All right. So good. Thanks, Tom, for the great introduction. And we'll just bang through this really quickly and get to the exciting part, which is really open discussion. So I was challenged with giving 3 practical tips that have helped me with pain management in the acute setting. These are my disclosures that we talked about already, and a lot of federal funding for this. And as we were discussing ahead of time, anyone who pays taxes paid for this work. And so that's the reason why we're going to give you whatever resources you want to do this. Really, my first tip is this isn't really about opiate restriction. This isn't about just, keeping medications from patients. It's really a balance of safety and comfort. And that's, to me, one of the biggest tips. If you approach it that way and have the discussion with the patient around that, I think that can be helpful. And it really motivates you to understand true multimodal pain management. When we typically say multimodal, people think it's some cocktail of drugs because we're sort of pharmacocentric here in the United States. And it actually turns out there are physical strategies for pain management and cognitive strategies for pain management. Tom's going to cover the CPG at the end, and so I won't cover it now, but when you really want to learn a little bit about those strategies for pain management, we have this resource for you that we published last year. The other thing that's a big tip that's helped in my practice and helped in the people that I train and teach is to prescribe with precision. Everyone was taught to prescribe medications this way. This is the way that I prescribed them for the first 10 years of my career. And what it does, it actually allows either nurses or your patients at home to triple their dose of an opiate and still be on prescription. There's really no other medication that we allow to triple the dose and expect it to not be a fatal result. If you triple your blood pressure medicine or your insulin, things go very poorly. And here's examples of, if you give 1 hydrocodone every 6 hours, they take 4 pills a day. If you give that range that we talked about, they can take up to 12 pills a day, 3 times the number of pills a day, and still be on prescription. The other thing is, if you utilize a resource we're going to talk about at the end, like the taper that we talk about, and again, don't use the word refill, use the word taper. You can't really fit it into the taper if we're giving wide ranges where patients have wide ranges of doses of prescriptions. So if you want to use a taper like this, You have to prescribe with precision. And then my final tip is to provide patients with patient-facing material. And Hassan's going to talk a little bit about a prescribing policy. And this isn't just our internal policy. We give it to patients. We give them information on cognitive therapies. And why? Because these are trauma patients. A lot of the therapies are not scalable. You can't go to a psychiatrist or a cognitive behavioral therapist for a lot of our patients, almost half of them. And so we give them resources where they can do this at home. And we have some great members of our team who've helped develop these. Cryotherapy does not have to be expensive. It can be some of these super fancy things, or it can be relatively inexpensive things that you can find in various online purchasing places. And things like this that have been around for a long time that have reasonable data to support their use, like a TENS unit, these are actually relatively inexpensive, easy to use, and really have almost no side effects, although I did have 2 patients that have had cutaneous allergies to the adhesive, so they're not without side effects, but they're pretty darn minimal. So this is my contact information if anybody wants any of this information, and I will stop sharing. And
so Joe, repeat your 3 for us.
Like off the cuff right now?
Yes.
So it's balancing safety and comfort is number 1. Number 2 is prescribe with precision. Mm-hmm. And then number 3 is the patient-facing materials and having those available and easy to distribute.
Like handouts, that sort of thing.
Like handouts, yeah. And we have them now where you can email them to patients in the COVID era. So we can just email it to them. So we have electronic versions.
All right, Hassan, you want to?
Yeah, sure. Let me.
Hassan, remember your 3, because he's going to ask you at the end once you're screen.
Oh, I made a conclusion slide. I'm good to go. And I didn't sneak in like 8 or 9 like you did, which made it harder to remember 3 as well. So thanks to Tom for the intro. So I'm down here in Florida, which is one of the epicenters of the opioid epidemic, and I've been dealing with this for 5 years here. And before I was in Tennessee, which was every bit as bad, if not worse. So I think the first tip I'd like to share that I learned, and I wish I had learned this right off the bat when I was even in training, but is to remind patients that acetaminophen and NSAIDs are pain medications, right? There's a drug cabinet there, and a lot of times we tell people, well, just take some Tylenol or ibuprofen if you have it at home, but that's not the way to get people to understand that these are actually pain medications. Because when you ask patients what they do when you tell them that, they'll take maybe 1 Tylenol every now or then, or take 200 milligrams of ibuprofen. And if you have ever had pain yourself and take 200 of ibuprofen, it doesn't do anything. So what we've gone to do then, and this is part of our guidelines, is to actually prescribe acetaminophen, actually prescribe NSAIDs in higher doses. And it's made a world of a difference. In fact, my refill requests when I was, first practicing 10 years ago, I would always assume that when somebody asked for a refill, they were asking for a refill of hydrocodone or oxycodone, versus now, even at their first post-op visit, the vast majority of patients, when they ask me for a refill, are asking for a refill of prescription strength ibuprofen. So it's really changed my practice immensely to prescribe these medications. And of course, with acetaminophen, you have to have a little bit more of caution with concern for toxicity. But you have to balance that with any combination opioid products that you're giving. And then with NSAIDs, you have to worry about other medical comorbidities. You don't have to worry about fracture union, which is covered well in our guidelines, and I'm sure that we can discuss a little bit later on. Second tip would be to discuss pain the first time and every single time you see a patient, because you'll try to run through a busy clinic and get out of the room without talking about it and hope that they bother your PA about it or your resident about it or your MA or somebody else. But if you just discuss it and take a minute to actually let the patient know you care about their pain, because they clearly care about their pain and may care more about their pain than your instructions or anything else going on with them, then it goes a long way to improving your relationship with the patient, your satisfaction scores, and their compliance and their pain relief. So it's just a win all around. The other time to discuss it, I think, is not just every time you see them in follow-up, but really the first time you meet the patient. A lot of time it may be in pre-op holding or in the ED, but to let them know that, hey, look, we're going to control your pain. We don't want you to hurt. Opiates are going to be part of it, but we got to do it responsibly. And the vast majority of, at least what I tell patients, is the vast majority of my patients are able to get off of opiates within a couple weeks after this, just so you know what to expect. The other thing, as an aside, most of my patients, the first time I meet them, my residents, forgot to tell them that they can't put weight on their P-line for 3 months and can't work for a while. So you may want to remind them about other stuff the first time you meet them as well. Third tip would be, as Dr. Shu mentioned, was the departmental policy. And it's not just to have a policy to blame for everything, but it's to have it so everybody's on the same page. If you have one of your partners doing something completely different than you and they're on call, then that's going to interfere with the way you want to manage that patient. Or you have your resident or your mid-level provider taking call for you or doing refills, and it's just totally random, then it really makes it hard to take care of patients. So I think having everybody on the same page with how you at least manage pain at a baseline. And then obviously there's going to be individual situations, and you can have that discussion then with the patient as to how you're going to proceed. But you want to be sure everybody's policies, like we put out the policies that'll be covered later on, you want to make sure that they comply with your state law, because every state is different with what they allow you to prescribe. And that they have true multimodal components, not just multi-drug components as part of those policies. So that's that. So in conclusion, the too long didn't listen version is give scheduled scripts for Tylenol and NSAIDs, discuss pain the first time and every time you see a patient, and have a policy to fall back on. Thank you.
Thanks, Hassan. That was great. I won't ask you to repeat them, because I'm going to try to throw up my 3 here right now. And it's just text. My first one is include family. When the patient is inpatient, when they are in the hospital, discuss the opiate plan with the family member, not just with the patient. We're in the habit of rounding pretty regularly, and I am stunned at the number of patients that will, well, before COVID, stick out their hand to shake your hand, but say to you in the clinic, nice to meet you. Like, a startling number of trauma patients are amnestic to the hospital experience, and that may just be mercy, but it's true. It's probably has a lot to do with the pain medicine they're on in the hospital too, but they don't have a heck of a lot of recollection. So some of the things you tell them about pain plan, et cetera, et cetera, et cetera, that's lost. But if you tell it to the person next to the bed, that's corporate memory. And I think that helps. The other thing I do when including everybody in the discussion is it's a negotiation. I think when I first started in practice, I'd say, well, so we're going to try to do this, that, or the other thing. You tell them, after this injury, people are on prescription pain medicine. We all practice in snippets, right? So people are on prescription pain medicine for 2 weeks, and after that, you're on Tylenol or ibuprofen. You may read on the internet that ibuprofen is bad for fractures, but that's scientifically unfounded, and I would prefer you be on ibuprofen than hydrocodone. That's that snippet. Now it's delivered. I discussed withdrawal. It is proven, and if you ask your patients, after 2 weeks, if they've been on opiates more than 2 weeks, they can experience withdrawal. Mike Baumgartner told me when I was a resident that if a patient says something to you about a problem and you have to explain it, then you're explaining it away. If you predict that problem in advance, you're Nostradamus, right? I mean, your stock comes up when you predict what's going to happen. You predict withdrawal. And what I tell the patient is you yawn, get itchy, you may get nauseous. I don't find they get nauseous until they've been on it longer than that. But the pain and the itching is early. What you tell the family member is they're going to get ornery or agitated. And they do. They're 3 or 4 days and they're just snarly. And it's funny because when you bring it up with the family member in the background, the spouse frequently nods like, oh yeah, no, we went through that. Mm-hmm. Yeah. So discuss withdrawal. And then lastly, there's a thing called opiate syndrome. That is opiate-induced androgen deficiency. If you give a male rat opiates, it suppresses their testosterone within 48 hours. The same thing is true of humans. And if you put them on an opiate chronically, they become hypogonadal. Some of the better pain clinics, if they have people chronically on methadone and such, you will find that they will actually supplement their testosterone because they're hypogonadal. So I find if I'm looking for a way to motivate a healthy young male trauma patient to come off the opiates, I discuss it preferably in front of his significant other, that it's suppressing his testosterone, and sometimes that is motivating. So I may be using the data to my advantage there, but it's what happens. Those are my 3. I discuss it with the family because I don't think the patients remember very well when they're inpatients. I applaud Joe and Hassan's point that, like, you can't discuss it often enough. And right, I used to try to sneak out of the room before they asked for a refill. You just ask them right up front, just get it over with, right? I discuss withdrawal, tell them it's going to happen. And then at least when it happens, they realize this is what's going on, and they know they got to get through it to get to the other side. And sometimes I discuss the hypogonadism if I think that's what needs to motivate them. So that's that. I see we have had a couple of chat questions in the chat, and our panelists have been knocking them out. I appreciate it. We are now going to go to a discussion. What happened there? We're going to go to a discussion, and the discussion is going to be based a lot around this doc here, this document. You can see Joe and Hassan are the first authors, and I think Joe briefly put up the list of, I think there's about 20 people, mas o menos, who were involved in putting together this. It is available, whether or not you're an OTA member, it is fully open access, thanks to JOT. And it really lays out very specific, even cookbook for various levels of injury. And it also has a lot of recommendations based on what the evidence is, And then I'm going to ask these gentlemen now about some of the things. We're going to use this as a little bit of a guideline for our discussion. So pain med strategy sounds like a very broad topic, but Joe, you use the term specifically multimodal analgesia, which sounds like, you say we're very pharmaco-focused. When you say, what is your standard? Like someone comes in, they've got an injury, and we just referenced the fact that there's sort of standard cookbooks for things, but someone has a tibial nail, besides what we expect, which is at least some period of opiates, NSAIDs and Tylenol, what else are they getting?
Yeah, so to me, it actually starts with a little bit of perioperative. They get preloaded with a gabapentinoid and acetaminophen, and then during the surgery, they're going to have a block typically, which is a whole separate discussion about using regional anesthesia on tibia fractures, and I have for years. So they're going to get a block, whether that's a formal nerve block or a periarticular style injection with a longer acting substance. And then postoperatively, I actually do what I call immediate intraoperative cryotherapy, which means I actually put Ziploc bags full of ice on the patient before they leave the operating room, and I apply their TENS unit in the operating room. And then from there, when they go to the floor, they're going to get, in addition to that, so they've already got some physical strategies like cryo and TENS. They're going to get aromatherapy as well. In the outpatient center, they get it in the PACU, and inpatient, they don't get it till they get towards their room. And then we have a couple of different strategies available for them in their room where they can have music therapy. When I say music therapy, it's basically on their television screen, they can stream Pandora. And then there's some other cognitive strategies that they can stream from their television as well. Because a lot of this is really designed to be scalable, where you're not requiring very high level resources to do this kind of thing. It can be really done at any trauma center.
All right, I'll bite. What's aromatherapy?
Aromatherapy is inhaled essential oil aromatherapy. And there's a variety of ways that you can do it. Our infectious disease people don't want us to use the aerosolizers. And so we basically just have a little plastic medicine cup with a cotton ball in it. And then you drip some essential oil aromatherapy into it. It's actually got really good data to show it has an anti-nausea effect. It has an anti-anxiolytic effect and a decreased pain and decreased opiate effect, strongest in the perioperative period. And so I can tell you that I get the most heat for talking about aromatherapy from the orthopedic trauma community.
What I'm doing. But
I can't see the chat, so if people are bombing me right now, I can't see it.
Oh, that's fine. But you believe in it enough to use it, and you say it starts in the PACU, and then they do it in their room.
In my outpatient surgery center, they have aromatherapy in the PACU. The inpatient setting is a little bit more complex. It's a huge PACU, and they don't get it until they get to the room.
Okay. Interesting. But I mean, and you point out there's references in the CPG, in the Clinical Practice Guideline, to support some of that stuff. Let me ask another nitty-gritty question before we move on to Hassan for a second. You said you put the TENS unit on them right there in the operating room.
That's right.
Is there evidence to support the fact that if you start it before they wake up, it makes a difference?
No, and oftentimes I don't start it until they wake up, and it goes it goes onto the PACU. And really, this is all about operationalizing it in your own setting. And what I found is that to have the nurses apply the TENS unit, they didn't know where they wanted to put it and that sort of thing. They didn't want to disturb the postoperative dressing. And so it literally takes less than a minute to apply in the operating room. So I put it on, I plug it in, and I just leave it off. And they have the patient-facing handouts. They understand enough about it, at least in the outpatient center. The inpatient center is a little less, it takes a little more hands-on. The resident has to go back and check on it. In the outpatient center, it's relatively automatic. The nurses go through it. And like actually today, I was in the outpatient center, and one of the TENS unit was not functioning. Probably the batteries were put in wrong or something like that. And so the PACU nurse called back in the OR. We switched out the unit before the patient went home.
And further nitty gritty, this sort of thing is covered by health insurance?
It's covered in kind of bundled together. And so if you're really looking at your margins for care, this would actually come out of your margin, but it's actually very inexpensive. The device itself is probably less than $20. It does get upcharged anytime you do anything in the medical realm, but it's still in the dozens of dollars. It's not more than $100.
Okay. All right. Hassan, differences from what Joe's doing? Things to add to it?
No, nothing really different. A lot of these things, we've kind of discussed over time, and we were lucky enough to have Joe here as a grand round speaker about a year ago when we could still travel. And it's a lot of the same stuff that we incorporated from his talk, with especially the one that I'm not that I really want to highlight, though, that he changed our practice significantly was, when we say ice, every hospital has these tiny little ice packs. That's not what you want to use. He impressed on our residents, and I got a couple calls as the program director. You want to use trash bags full of ice, like really big bags full of ice. And then you're telling
me the volume of ice matters.
The volume of ice matters. You need to use a lot of ice because it actually works. Try it on your own arm or leg the next time you have an injury, and especially through a splint. You have to use a large amount. The part that they missed out on was using the emulsifier powder in the bottom of the bag, so when it melts, it doesn't get over the bed in the patient rooms. That's when I got the calls from nursing staff. But remember that part too, to use the emulsifier in the bottom of the bag.
All right, now we got a bunch of questions already, and rather than listen to my questions, let's have other questions. I am failing to manipulate this thing properly. All right, acupuncture. Joe, you've recommended all of the stuff that's, I would consider avant-garde acupuncture?
So there are actually some reasonable data on acupuncture, and I'm actually honored to be a part of a clinical practice guidelines in development now that follows kind of the strict academy guidelines. And there's some pretty favorable data towards acupuncture. And so some of that will come out. The definitive trials have not been done, obviously, but I think that there's some really promising stuff. The real challenge that happened prior to this, and the reason why we haven't recommended stronger is insurance companies didn't pay for it. You're really out of pocket for acupuncture. There are some insurance companies that are now willing to pay for acupuncture. And so I think that if it's available on a patient's health insurance plan where they can afford to do it, I think it's a reasonable thing to consider.
Yeah, you know, I will say that it's something that's been kind of outside of my practice realm, but I got to spend the month of January working orthopedic trauma in Bhutan, and they're very knowledgeable with that sort of thing there. And I was impressed with like the kind of immediate results that I saw from some of the practices. It's kind of interesting. Hassan, there's a question about TXA as part of your pain management, as hematoma can be a source of post-op pain. Anybody put that in the pain management realm?
So I use TXA. I used it on 2 cases today, but I have never really considered it a part of my pain management realm because I don't use it standard on a majority of my cases. But it makes sense. The question, I guess, was about hematoma causing pain. Hematoma certainly can cause pain. And I certainly use TXA in large surgical exposures. I'm a fan in both topical and or IV. I've been using quite a bit more now.
Okay. Muscle relaxants. I heard gabapentinoids mentioned, NSAIDs, etc. Muscle relaxants. Either of you?
No,
I'll tackle that first. So I actually do not use muscle relaxants in my practice as a standard. I think that, you know, most of the times with the combination of things that are part of our guidelines, we're able to control pain pretty well, and they can have a sedating effect and other side effects I don't necessarily want to deal with. I think a lot of times muscle spasms in response to pain, and at least that's what I counsel my patients. So I don't use them as part of my practice.
Joe, any different thoughts on that?
About the same and the same logic. And if you look at the first few days post-op, when people have the most pain, that's when they're taking the highest morphine milliequivalents per day. And so if you're over 50 morphine milliequivalents per day, you're already at risk for overdose, and you add the respiratory depression and muscle relaxant, I think things can get a little bit dicey.
Yeah, I've been, and there's data to support it too. I'm not sure the muscle relaxants are actually altering your somatic pain. They're altering the amount you're able to complain about it, I think. Seriously, they're sort of sedative, obviously. NSAIDs, we all three have clearly expressed that we think that NSAIDs are preferable to not NSAIDs, or NSAIDs are at least preferable to be on an opiates. Any of you have a limit on how long you might prescribe those? Do you think the effect, if there's an effect, do you think the effect is chronic or?
No, so I don't really have a limit on how long I'll have a patient on NSAIDs, but in general, with these approaches and with appropriate mobility, et cetera, most of my patients from acute injury are off of them within, I'd say by the 6-week visit, they're taking limited NSAIDs, and certainly by the 3-month visit. I think that if you look at the non-union risk with NSAIDs, any of the literature you look at that where it was, you know, it's not great evidence, but the thing that seemed to make a difference is if people were on high dose for really long periods of time, increases your risk with fusions of certain type. And then obviously from the medical side effects with renal, GI, cardiac, et cetera, if you're on high doses for longer periods of time, we're talking several months, is when you're going to increase those risks for most non-selective NSAIDs. Now, the caveat to that would be would be ketorolac. That needs to be much shorter term.
Okay. And on the ketorolac, any of you have a prohibition on IV ketorolac at the time of osteosynthesis?
No.
No. No, and the pain.
I use it a lot, and it's actually written into some of our order sets that are the CDC funded work as an option. But for my cases, even non-union surgery, osteotomies, limb lengthening, I use it.
Yeah, the metric pain study looked at, that was one of the limbs in that, and that data we hope will be published in the next calendar year. And we have a DoD grant now. If you work at a big center in the United States and can randomize your tibia fractures, I am here to recruit you because we're randomizing tibial nails to NSAIDs versus not NSAIDs to put this to bed once and for all. So please reach out. I'm going to open the lid on this discussion. I had skipped over a couple of these questions. You guys are still seeing my slides, or are you seeing the questions? You seeing my slides?
Both. I found the Q&A too.
Okay. All right. Joe, I heard you say that you'll use nerve catheters for tibial nails.
I don't use a lot of nerve catheters just based on cost because they're a little bit expensive to send home. I have no problem with it, and I've sent home several patients with them. Most of the blocks that we're doing are single shot blocks. Of course, the big things people are freaked out about is compartment syndrome. And if you really look at that data, it's conflated with epidural anesthesia, and there really aren't good cases in any real data that a peripheral nerve block can mask compartment syndrome. The other thing that actually—
Have you ever diagnosed compartment syndrome in somebody with a block?
No, and we've looked at this pretty carefully. And the problem with this whole question, when people want the definitive answer, is the event rate is so low for compartment syndrome. It's nearly impossible to study, as the big metric study PACS is really struggling with the event rate being so low for compartment syndrome. And so, but we looked at some of the other factors and some of the other things, and you know, at least our goal with some of these publications is at least to put a series out there for those people that want to use nerve blocks in these fractures, to have a safety study to point to should a rare event occur for them and they feel like they're in a litigiously bad spot. The other thing about nerve blocks to be careful of, and there are some good studies that actually even describe true rebound pain that can occur. The thing that some people would suggest is to load people in opiates and things like that to prevent rebound pain. But I think that's where your cryotherapy really helps you, your ice helps you. It's actually been shown to slow your nerve conduction rate. And so with the combination of the ice and some TENS units and some other strategies around that, the rebound pain has been less problematic in my practice.
All right, I will strongly take the contrary opinion on that. We
on
don't
the rebound pain?
No, not on rebound pain. That's the thing. We do not use, we use a lot of nerve catheters. 15 years ago, we published on sending calcaneus home, which I felt was, anathema when I was a resident. What you did was stay up all night trying to make the calcaneus comfortable. But I'm very comfortable with catheters. We use a lot of catheters. They have a good safety record by and large, but we won't do them for tibials, tibia shafts or tibial plafons. And I have seen compartment syndrome of the lower extremity masked by a catheter. So I just offer, as you say, the event rate is so low that it's hard to publish a safety paper, right? Because the event rate is so low. Did it, were you able to detect it, or did it just not happen? What's your thought on this?
So we use a lot of regional blocks here, and I have no problem using them for bicondylar plateaus, or we don't do a lot for tibial shafts, but I would personally use them, but I have not seen a missed compartment syndrome after regional block. We do quite a few field blocks as well. So I'm all for local analgesia because I think that if we all have experiences of seeing something happen a couple times and it changes our practices. We're all guilty of that in multiple ways in our practices, but that's just one that I haven't personally been burned by yet. So I'm still going to use blocks because I have seen plenty of patients miserable after these big surgeries.
Have you ever diagnosed anybody with a block and a bicondylar with compartment syndrome?
No, but on the flip side, I've never seen somebody come back later with, a motor deficit or sensory deficit later on that indicated that I missed their compartment syndrome after a block either. So
Yeah,
I
I
don't
just
know
wonder,
that,
like, if
yeah.
the event rate's 10%, compartment syndrome and a bicondylar, and you block 20 of them.
Yeah.
What,
Yeah, we could beat this question to death all night. I think there's some other questions that.
Okay, all right. I just wanted to be crystal clear to the audience that it's not settled.
Oh, I don't think any of us claim that, Tom, but the
No,
challenge is that the people that are so anti-block are super passionate about it. And so, we don't want this to hijack a webinar like this. So I think we should look at some of the other questions as well.
Okay. Someone asked about CBD oil.
I'll let Joe take that.
So I had the honor of, we're part of a review on some of this cannabinoid work, and that'll be published soon in JBJS American is going to publish that. It's just a guide for orthopedic surgeons. There is some actually low-level data that CBD can have an anxiolytic effect, and as you know, anxiety and pain are intimately tied. And so maybe it can have an effect. The problem now is it's been almost used as a surrogate to really bring medical marijuana and even recreational legalization of marijuana to the world and say this is the way to prevent opiate-related problems. And if you look at cannabis now, the THC rates have climbed while the CBD rates have been relatively flat. And so that's really not what modern marijuana is about. Modern marijuana is about the hook. It's about the euphoric hook of it. And so that's the only thing I'd say about CBD oil. But in and of itself, it doesn't seem to have that much downside. The interesting thing about CBD oil for me that's most interesting is when I was discussing essential oils, everyone laughs when I talk about essential oil aromatherapy, and we have gobs and gobs of data on that. But CBD seems to actually be this, new wave, and everybody's really excited about it. And so I said, you know what, maybe try lavender, maybe try peppermint oil. There's a lot of good data on some of these other oils as opposed to CBD. But I think the downside of CBD in and of itself, just CBD, if that's actually what you're getting, seems to be relatively low at this point.
Hassan,
thoughts on CBD or THC for that matter?
So on the CBD side, we've actually, I haven't prescribed it to any patients yet personally, but it is available in our clinics, and I have partners who are prescribing it to patients, and patients swear by it and say that they do have feel a modest effect, and are, especially when they're further out from injury, and with our state laws that are pretty restrictive on opioid prescribing, it's an alternative that has, as Joe mentioned, minimal downside if it's purely CBD versus the THC side. I think the THC side, I would recommend trying to stay away from.
Okay. Couple of questions on what you brushed up against, Hassan. The idea of field analgesics. Someone mentioned Exparel by name, or local analgesia injected around the wound, or even opiates placed in the wound.
Yeah, so I've used the long-acting bupivacaine, and it works, but there's plenty of literature out there to suggest that it may not it's quite expensive and may not work any better than stuff that you can mix on your own. Most of your arthroplasty partners have already been using joint cocktails for a long time. Ours certainly do, and we've started using them around our periarticular fractures and actually have a prospective randomized study that we're currently doing looking at that. So I think field blocks are great, and there's various recipes that are out there, but if you look in the arthroplasty literature, they've done a good job of defining the various components that go in, and they all potentiate each other.
Yeah, I know my partner, Dr. Haller, and Patrick Kellum are currently doing a blinded study on field blocks and bicondylars funded by the OTA, and I'd be curious to see what we learn. So, what about I just had it here a second ago. Any of you routinely for your chronic, two questions on chronic pain patients. Do you have what's your approach, and do you have a separate approach for the chronic pain patient, or do you just say they are the same as the rest of the population, we're going to do what we do, or do you have a special program for them? That's question one. Chronic user.
Let me ask a question to your question. You're talking about hot coming in the door, or you're talking about someone who comes to your clinic with a non-union?
No, coming in the door.
All right, hot coming in the door, you don't have the opportunity to taper them. And that's a different thing. And I actually get directly involved in the tapering rather than sending them to a pain management doctor to do for an elective one. But hot coming in the door, you have no idea, you have no way to taper them. And so that's where having a true multimodal approach is really going to help you, because they're at very high risk for having prolonged hospital stay, perioperative complications, to include escalations in care and need for rescue naloxone. It's really your highest risk group that come in on a chronic opiate. And so that's where having these true multimodal approaches is really helpful. There is a subset of patients, and we manage that ourselves with the resources that we have in orthopedics and the order sets that we created. The other small subset, not really chronic pain, it's your active heroin users. That's a different subset where I really think that you need outside help to manage those people. And so those are the people that we get the acute pain service involved in for that. If you get acute pain service involved in everyone, it's a little bit overwhelming to a relatively scarce resource. So that's kind of our algorithm, or at least mine.
Yeah, so I do the same. I get the acute pain service involved while in the hospital, and then let them know the first time I meet them that, look, you're taken beyond what I can legally prescribe in my state and beyond what I can manage. But on the flip side of that, at that first meeting and every time I see them, and I've had patients get really angry with me for it, I try to talk to them about getting off of opioids. You'd be surprised at some of the conditions that people are on chronic opioids for that they don't need to be on them, and it still happens. And so because at least in our state, and I'm sure some others, there are a lot of restrictions on writing opiates for acute pain. The chronic pain patient can get as many as they want forever. There are no restrictions on chronic pain in Florida. It's amazing. I've actually been successful getting quite a few patients who are on chronic opioids to question their treatment and to actually switch to pain providers who I know in the community who will help patients wean off and have gone that route with it.
I mean, that's a really smart strategy too, Hassan, because, as you know, outcome data can be driven by whether or not a patient's on a high dose opiate, to include things like reoperation rates in the total joint population, to include their response to physical therapy and return to work actually is lower in a chronic opiate or a higher dose opiate patient. So these are things that actually can matter to your outcomes. And so you can leave it in the hands of someone else and say, this is not my problem, and go to someone else to manage this stuff. But if you're not actively involved in trying to, and you can taper these people, and a lot of them can taper themselves. Beth Arnold's a pain researcher out of Northern California, and she has a very, patient-centric approach to a lot of this stuff, because it's really a balance. It's not about just restricting opiates. And she actually has some data that patients can self-taper. And they actually probably do it as well as a physician guided. If they're motivated to do it, they can really self-taper. And it's really, they can just count pills and taper themselves.
But the motivated to do it thing, right? I mean, that's kind of, they got to want it. I think that's
but Tom, isn't that the majority though? I mean, even people that are on, chronic medications and stuff that come in, I think the majority of them don't want to be on it anymore. They want a way and someone to help them come off it. That's what I think. I think it's the smaller percentage of those patients that are these extreme outliers that are really problematic for your clinic. To me, taking that approach, I actually think that the majority of them have done well.
Yeah, I'll tell you, you'd be amazed how many patients on chronic opioids, when you talk to them, aren't happy with being on them and would like to get off of them, but they may be stuck in with either a primary doc or a pain provider who hasn't really given them alternatives. And it's whether you want to taper them yourself or find allies in the community who are pain providers who are doing things the right way and who are willing to take those patients, that's a huge resource that I can certainly do for my funded patients, and I know we have an international audience and a lot of people are in countries where there's universal health care, or we also have people in the audience I know who are from environments which are similar to ours, where not everyone has health insurance and can't get access to resources. And those are the ones that are really more challenging. But for your patients that have access to resources, getting them and finding out who the responsible pain providers are in your community who will do non-opioid care is a huge bonus in your practice.
And then are there patients that in that category that you routinely send home with naloxone?
It's in Florida, it's the state law. If you write an acute opioid script, you have to write a script for naloxone. Now, whether they fill it or not is a whole different story. But you have to write the prescription. It's part of our standard prescribing.
Wow.
What's interesting about the naloxone too is that it actually introduces a discussion around this balance of safety and comfort, because then you can it opens up the opportunity for you to talk about, hey, you're at more than 50 morphine milliequivalents a day, you're at more than 90 morphine milliequivalents a day, and it really changes discussion. Like Tom, you said, talking to the family, when you give a prescription to a spouse and say, if your family member overdoses, this is how you save their life. It changes their respect for the opiate. And that's why we put it into some of our decision support work, even though when we look at our data, it's actually one of the lowest things that people respond to when we suggest them to do it, because it's not mandatory in our state. So based on the number of morphine milliequivalents, over 50, the CDC recommends naloxone prescription. Most of the docs and most of the APPs, if you give them that prompt when they're writing the prescription, they sort of ignore it because they, but if you actually go through and we put it in there, because having that discussion with a family member, or at least someone giving them that prescription, or a prescription like Hassan saying that they have to refuse, it changes the conversation to a certain extent.
Couple of questions now about Ultram or Tramadol. Sort of, I know in a lot of practices that's used as kind of the middle ground, your quote off of opiates, going on to over-the-counter medicine. Where does that, and if so, where, fit into your practices?
Hassan, you did the taper.
Yeah, so it's actually part of our opioid tapers for the non-operative injuries or for minor musculoskeletal injuries. And because it is an opioid, it acts on multiple receptors rather than one specific receptor, so it doesn't have quite the high, for lack of a better term, right now. But it is certainly an opioid and certainly can be habit forming. So we use it but sparingly, and you have to remember that that it can have negative consequences if you give high dose and long term.
Do you find it's an effective bridge medicine in people who have had more chronic use or are more experienced?
So I have used it as a bridge medicine in that situation, and also for somebody who's just, you know, they're wanting to get off of the stronger hydrocodone and want to just wean down, but they still have a few left and are trying to work their way down to NSAIDs. So I've used it in that situation, and also, but for the chronic pain patients, that it's not even on the radar. A lot of them, quote unquote, have an allergy to tramadol and everything else other than Dilaudid.
That is a challenge.
And for our international audience, it's a significant drug of abuse internationally. I think it's probably less so in the United States because you could go get OxyContin like that up until a few years ago. But it is a significant drug of abuse internationally, and it causes seizures. It's actually one of the problems with it. And I think that's one of the things that are seen internationally. It's less often seen in the United States because we have such a fentanyl problem right now.
Yeah, I think it's seizures, and what's the other thing? It'll give you a prolonged QT in some subset of the population. I've reached the extent of my knowledge about EKGs right there. I want to ask you guys, we're talking about cognitive therapies. Joe, my frustration has been with, with handouts and that sort of thing. I was in the hospital a couple of months ago. I had surgery, and my wife was telling me what was in the handouts because I didn't read them. I don't know that people read the stuff they're sent home with, and so people try giving people links to cognitive behavioral therapy programs, etc. Like, do you find that you have success getting people to avail themselves of those resources?
So what I will tell you is that the cognitive stuff is actually the hardest to get patients to buy in, especially trauma patients. Appealing to the family is often the best thing. And so when I go to the family member, when you bring up things like Headspace, it's a free cell phone app, Calm is actually cool now because you got NBA players making television commercials for Calm. 6 years ago when we started talking about this stuff, everybody's like, who is this quack talking about Calm? But now it's cool because we got professional athletes talking about it. But the one that they actually will use the most is, and probably second most, is actually aromatherapy. People are kind of open to it. And you kind of get them started maybe with candles or something like that have essential oils in it. But the number one is music-induced analgesia. And there's actually really good data on playing music. And it's whatever music the patient likes, right? So unless it's like death metal or something like that. Not to offend anyone.
That's true.
But it turns out that the patient, there's all this data on the cadence and the tone of the music and that sort of stuff. Okay. But the best data is that the patient chooses it and likes the music, whether that's gospel music, country music, classic rock, whatever it may be. There's data that decreases your perception of pain and increases your pain tolerance. And they even have good studies done with cold tolerance where they're dunking someone's hand in freezing water and they can actually tolerate it longer. So it's a very objective thing. They can tolerate it longer if you're playing music. And if you don't believe that this is true, the next time things get tense in your house, if you can, I have no financial relationship with Sonos. I wish I did, but I just kind of sneak over to my phone and I click the Sonos on, and it has a calming effect. And as we talked about, anxiety and pain are interlinked. As the people's anxiety raises and they start to develop concern about the relief of their pain, it actually elevates their perception of pain.
Yeah. The other one that I frankly haven't looked up to see if there's data on this or not yet, but you know how distracted ourselves we get with our devices, and think about your children on their devices. You could literally punch my son in the head when he's on his iPad and he wouldn't notice, right? So are as much as they can be, there's a downside to being distracted by your devices with whatever you're doing. They do release endorphins. They are, there's certainly something to that. With a lot of these things are distraction therapy, right? You're trying to train your mind not to focus on pain. So I've told patients like, hey, look, because especially at nighttime, how many of your patients have said at night things are the worst because they have nothing to distract them? I'll tell them to put on some music, go online, do other things to get their mind off of their pain, and it certainly helps. And that's something cheap and easy that that we don't often talk about.
It's interesting. There is data on it, and the iPad example you brought up is actually almost right on. They did a randomized trial of starting IVs in children, those with a tablet, those without, and actually decrease their pain response with it. And I agree, especially my oldest boy, if he has any type of device. There's also a study on watching a comedy, actually in the chronic pain population, watching a comedy decrease pain response. So I think there's actually something to what your notion is. There's a few studies here and there that support exactly what you're thinking.
That's very interesting stuff. One other thing I was going to ask about, and sorry, I'm going to go back one slide here because we got a couple of questions, people asking what the reference is. I'm just going to leave the reference up so people can see it for a second. We routinely measure promise, anxiety, depression, PTSD, the PCL, which is a PTSD instrument in the clinic. We're not running the PCL now, but that's well and good. And I'm thoroughly convinced that, greater than half of pain is anxiety. And there's, again, good evidence out of Hopkins to support that. I don't know what to do with that information, right? They say talk is cheap, but talk therapy is insanely expensive and in short supply where I live. Do you guys routinely make use of psychologists or psychiatrists in your practice? And if not, what do you do instead?
Hassan?
Yeah, so I wish that we had those resources to do it more. For our underfunded patients, we just simply don't have the resource at all. And then even for our well-funded patients, the availability and access to get scheduled during that time of initial recovery when they kind of need it the most in the first couple months when they're off of work and losing income and in pain and depressed, it's just hard for them to even get in a timely fashion. So it's a major hole in our system here in Tampa. And we're actually, I believe, part of a work group now being led by Dave Ring and some folks that's looking across the nation and internationally at highlighting this issue and trying to come up with suggestions to help our healthcare system better address this.
The one thing I'd share is we talk a little bit about it in the guidelines, but there are actually some anxiolytic effects to gabapentin. It's one of the reasons why I like to use it. And people can quote studies all the time about pluses and pros and cons of it. So I think that that's something that you have already. I talked a lot about the cognitive stuff that we do that some people will take and some people won't. There's a trauma survivors network that is, we have it more available in our facility. It started out as a metric study and has actually been ingrained a little bit into what we do in the hospital pays for those counselors now that are there, but it's really developing a peer network. And even if you don't have it at your center, if you go to Trauma Survivors Network, there's a website and and the patients can access that and even enroll in some of these sorts of peer counseling. And I think that that's actually been a huge weapon for us with this. We have some work in progress as well that's being pretty aggressive about some of the screening work because we're screening this in the clinic as well. And I've collaborated with behavioral health telehealth because as everyone has a challenge, the behavioral health resources in this country they're absolutely overwhelmed. They're under-resourced, they're underpaid. It's a real challenge, even though it's probably the driver behind most of what we do. And so our team has actually been pretty good about doing telehealth. And so what we end up doing is I have little webcams in my clinic. It does slow down the clinic if someone pops positive on the PHQ-9. So we screen people, and if they have depression symptoms up to a certain range, as long as they're not suicidal, then we talk to them a little bit about potentially starting on a medication. If they're willing to do so, I'll potentially start them on an SSRI and SNRI, which actually has some data that is very useful in the perioperative patient population. Behavioral health telehealth calls them within 2 to 3 days, make sure that they're safe on those medications, and then bridges them to their primary care physician that takes it over from there. The problem is just what Hassan talked about, though. If they're uninsured, they don't have a primary care doctor, there's really no one on the back end, and they're probably not going to pay for the medication anyways. And so they're a particularly difficult patient population.
All right, I'm just spinning through the questions, and I think we've addressed almost all the questions. There was one said that if opiates suppress testosterone, do we need to start testing our patients? I think the easier solution would be to get them off the opiates than to have to start writing them for testosterone. We even actually studied this in rats, and we gave them supplemental testosterone, and it did not reverse the effects it was having on the skeleton, and the rats got ornery.
Could they do more push-ups?
They honestly, they were angry. You asked the resident involved in the study. He's got scars on his hands. And then Joe, there's one question about animal therapy. If we can hit that briefly, then we're going to wind it all up because we're 10 after the hour.
Yeah, that's a service provided by our hospital. And so, like I said, the patients go in on their television, they can select that they want pet therapy in the hospital. And we actually have volunteers that will actually come and they'll bring a pet to your room. And so that's actually a purely volunteer service. It costs us absolutely nothing, and the patients can order it for themselves. So it's really, I think it's not used a ton, but every time you're making rounds, you'll see one of the pets kind of cruising around. So they're going to see someone.
I have noticed during COVID, it's way harder to get your patient's relative into the hospital, but we do seem to get patients' dogs into the hospital. I mean,
do they have to wear a little mask?
No, I guess they're not. I guess your dog can't give you COVID or something. All right. I very much appreciate the time of both of you guys. I very much appreciate the attention of our audience. And like dozens of questions, you know, I had a long list of not good questions, and we got 25 questions from the audience. So thank you very much. As I said, when I stop yammering, you're going to have to answer 5 questions. And then in the next 24, the 3 of us are going to post all of our resources to Ron at the AO. I want to thank Mackenzie, whose name you can see, but you can't see her picture, for helping to make this happen tonight, and as well as Sharice and Ron, who helped put it together. In summary, I think we heard that these guys have thought about this a ton. They have protocols. There are resources like this that are available to you, and they spend a lot of time talking to patients about it, and they spend a lot of time thinking about it. I think we saw that we've made progress on this issue. We've made progress on it, but it's certainly not gone away, and there's plenty more progress to make. I personally have learned that you got to open your eyes to some things that, as surgeons, we don't always embrace, but that appear to be effective. You guys got anything to add?
No, this has been great.
I enjoyed it. I really like the format of just being able to talk about practical stuff that we're all doing.
Cool. Good. All right. Well,
I agree. I'll double down on that. I mean, if more webinars and things are like this, I mean, you really get down into what people are actually doing rather than what they prepared on the slide.
Cool. Good. Well, hopefully that was helpful for folks. You'll have an opportunity, I think, in the next couple of slides to give some feedback on what you thought of it. And as I said, you should get a link, hopefully, from Ron in the next couple of days as to what where those resources are. All right. Thanks very much to our panelists. Thanks very much to our audience.